Thank you. Thank you very much for this kind invitation. And I would like to thank the organizers and particularly Professor Emmanuel Stips for inviting me and for giving me the opportunity to present this talk on rTMS in psychosis and cell app follow-up. So today I will focus on auditory verbal hallucination and rTMS because we have time limit, but I could answer a response regarding negative symptoms in the discussion section. So why using rTMS in auditory verbal hallucination? Auditory verbal hallucinations are very frequent in patients with schizophrenia, and they are found about 70% of patients. They induce strong disability, but 1/3 of the patients fail to respond to antipsychotics. So it is very important to develop new therapeutic like rTMS. So the principle of rTMS is quite simple. The principle is the current is discharged in a coil. And this current creates a magnetic field. And this magnetic field depolarizes the neurons. So you create an electric field in the neurons. And this technique is very relevant. And there are two major advantages because it is a non-invasive technique and it is well tolerated. There is only one major side effect. This treatment can induce convulsion, but it is prevented if you respect paradigm of stimulation. So in 1999, the first study showed that low frequency at 1 Hz rTMS applied on the left temporal cortex reduced auditory verbal hallucination. And further, there were a lot of studies confirmed these results, and the first meta-analysis in 2007 showed a large effect size at 0.75. However, further studies did not confirm these promising results. And you can see the last meta-analysis in 2021, the effect size was quite low at 0.19. So from this result, we might conclude that rTMS in auditory verbal hallucination has a quite low efficacy. However, if we look at the study, we can observe that you can observe a greater side effect if you use a specific scale assessing auditory verbal hallucination. You can see here with the auditory hallucination rating scale, we can observe an effect size at 0.24 compared to 0 if you use a PAN subscale. And moreover, if you use neuronavigation, you can also increase the effect size obtained at 0.39. So you have to keep in mind these two important points. First, using neuronavigation, and second, using a specific scale assessing auditory verbal hallucination can increase the response of rTMS. And if we look at all the studies on rTMS, we can observe a very large variability between studies and between meta-analysis, but also large variability between subjects. We can observe that some subjects can respond very well with a quiet remission, while other people do not respond at all. So how can we explain this variability in efficacy of rTMS. And we suggest three major factors which can explain this variability. The first one is the location of stimulation and the method to target the stimulation of the brain. And the second factor might be individual variations, and particularly anatomical variations, placebo response. And the third one might be the stimulation parameters, and particularly the frequency of stimulation. So look at the first factor, the location of stimulation. It is well known that auditory verbal hallucinations are linked to the language network. During fMRI, if you register the brain, you can observe a lot of clusters of activation while the patient is hallucinating. So you can observe activations in frontal, parietal, temporal lobe, and even in hippocampus. So there are many areas where you can target rTMS. And one study in 2007, conducted by Hoffman, researched the best location to obtain the best efficacy of rTMS. So it targeted several areas and evaluated the best efficacy. And the conclusion of this study was the best location, the best region is on the left temporal cortex. So how to manage the location using fMRI is not possible in practice. It's too sophisticated. It's not available everywhere. So there is a common method based on the T3, P3 site according to the 10-20 EEG system. And so you can locate the target as a mean point on the T3 and P3 site electron. But it is a rough estimation because if you project this site on the brain, you can obtain a very large variability of the projection of the site. As you can see here, sorry. As you can see here, there is a large variability of this projection of the site. So because of the pitfall of this method, and because we cannot use a functional MRI in practice, we try to find criteria to locate the target accurately on the brain. And from this previous study, it was a functional MRI study with rTMS. And in this study, we applied rTMS on the highest cluster of activation. As you can see here, it is represented by the green square. Here. And the patient during fMRI listened to a language task. So we targeted on the highest cluster of activation. And as you can see in the 11 patients, we can observe that this functional cluster is closely at the same location in this 11 patient. That means that we could determine anatomical criteria to locate accurately this location, this target to stimulate. And this target is located, as you can see, at the crossing of the projection of ascending branch of sylvius, it is in blue, on the left superior temporal sulcus. And in fact, it is very, very easy to locate, to determine this site, even from psychiatrists or even for people who do not know very well anatomical brain. I don't know if it's work. No. So it doesn't work. I don't know why. So it doesn't matter. You can load the MRI, individual MRI, and you can locate the sylvius ascending branch, and you project the ascending branch on the left superior temporal sulcus, and you can obtain the very, very accurate target to stimulate. So let's see the second individual, second factor explaining this variability in rTMS, and particularly individual variation and brain variation. One of them is the distance between the scalp here, where you put the coil, and the cortex when you stimulate rTMS. And we observe that this distance is very variable from one patient to another patient. As you can see, this distance is from 29 to 37 millimeters. And we showed that there is a strong correlation between the reduction of hallucination and this distance. The shorter distance, the better the efficacy was. And moreover, we know that the magnetic field decreases very quickly with the distance. So we suggest to adapt the intensity of rTMS with these parameters, distance. And why? Because you know that schizophrenic people has very often cortical atrophy and reduction of gray matter. So let's see another factor of variability is the placebo response. Placebo response is very usual in any clinical trials, and we can expect a very large placebo response with rTMS because of the technique. So we computed the amplitude of the placebo response in a 30 control study in rTMS in auditory hallucination. And we took into account the kind of the call of placebo. In fact, you have three choices for the placebo in rTMS. You can have an active call put at 45 degrees from the scalp or at 90 degrees of the scalp, or you can have a sham call. Sham call is the same as active, but you do not deliver any current in the call. This sham call just simulates the noise of the machine. And what we observe is in this group, we observe a greater effect of the response of placebo. That suggests that there is a placebo response added with an active effect. So in a comparative trial, if you use this kind of call, you could observe a difference between group, and so you could lead to an absence of efficacy of rTMS. So let's see the last parameter, particularly the frequency of stimulation. It is well known that on the motor cortex, if you stimulate with low frequency, you induce a reduced cortical excitability. But if you stimulate the motor cortex with high frequency, more than 10 Hertz, you increase the cortical excitability. So it is recommended, from base of this observation, it is recommended to use low frequency in the treatment of auditory hallucination. But in my opinion, this choice can be questioned. Indeed, there is some evidence that high frequency can induce efficacy in the treatment of auditory hallucination. And the first observation was from an open study where we observed a very drastic reduction of auditory hallucination with rTMS at 20 Hertz. We also showed that 1 Hertz or 20 Hertz on the temporal lobe reduce cortical excitability. And in this study, we use the paradigm of auditory evoked potential. And we observed whatever the frequency, 1 Hertz or 20 Hertz, we observe a reduced P50 amplitude, meaning a reduced cortical excitability, and it is represented here by the reduce of P50 amplitude. And moreover, some clinical and research studies show that 20 Hertz compared to 1 Hertz or continuous theta burst stimulation induce similar and significant improvement of auditory hallucination. So there are quite evidence to think that high frequency can have an effect on auditory hallucination. And we did a control study with 20 Hertz using the anatomical equivalent location for target stimulation. We use neural navigation, and we also use a sham call. And the treatment of rTMS lasted 2 days with 2 sessions a day. And as you can see, this treatment with high frequency is much shorter than the treatment with low frequency. Low frequency, we need 2 weeks, at least 3 weeks of treatment. And after 14 days after the rTMS, we observed that 36% of patients respond in the placebo group compared to 9%, in the active group compared to 9% in the placebo group, and the difference was significant. Unfortunately, this efficacy did not maintain over time. That's why we conducted at the present time another study with the same paradigm, same stimulation, 20 Hertz, neural navigation, target in a accurate location. But the originality is to stimulate the brain for 4 months. And we repeat the stimulation every week for the first month, and every 2 weeks for the next 3 months. And the originality of this study was, or is, also to include a device and digital device. This device was developed with a company, for lab company, and it was designed from a self-assessment of auditory verbal hallucination. And this device allows the patient to declare auditory hallucination at any time. And moreover, it allows the patient to self-assess their hallucinations at any time too. And the patients can respond 13 questions with 9 responses score from 0 to 5. And patients and doctors can have a feedback on their score, and they can follow the evolution of intensity, severity, impact, and so on. So they can compare evolution of hallucination with the change of treatment. So to conclude, I will say, and I will emphasize on three points. First, we need more trials with high frequency before concluding that rTMS has no efficacy or has too low efficacy in the treatment of auditory hallucination. And if you want to evaluate rTMS, if you want to evaluate the efficacy, we should use a specific scale assessing auditory hallucination. We should neural navigation to target accurately the brain. And if you do a comparative trial, you should use a sham call. And finally, I would say that Cell-App is a great tool for an ecological momentary assessment of auditory hallucination because it allows to integrate self-assessment. And we know that self-assessment can increase the recognition of symptoms by the patient, can increase their insight, and so can increase their empowerment in the treatment. Thank you very much for your attention.